to Professor Andrew Shennan, who's going to talk about the increased incidence of eclampsia in adolescents in low and middle income settings. And he said in the title on the program is an opportunity for action. Andy's, as you already know, that he's in Sierra Leone, so we're keeping our fingers crossed about his Wi-Fi connection. But Andy, over to you and see how it goes.
Yeah, no, thank you, Jimmy. And actually, it's really great to follow on from you and a team, because I think the subject matter of this brief talk, it won't be too long, is relative to the kind of pathophysiology of preeclampsia and the immune kind of, theories behind it. And it's just an observation that I wanted to share with everyone, because I think we're finding it quite interesting. I think, certainly as a piece of the cake, preeclampsia is quite large in the world as a cause of death. In fact, it also attributes a lot to PPH and sepsis as well. So it's actually bigger than the sort of 1 in 5 quoted. I think I just wanted to hone in on a subgroup that I've realized is really quite important. This came about when we did a study in South Africa, where in 3 hospitals, namely Groote Schuur, Tygerberg, Kimberley, we collected every single preeclamptic patient's clinical details systematically over 1 year. And rather surprisingly, we looked at the ability of different demographic features to predict eclampsia, and surprisingly, we found some things that I don't think are always revealed in the data sets that we see from high income settings, simply because they don't have the large prevalence of eclamptic pregnancies. So first of all, preeclampsia occurred, was equally prevalent at blood pressures of 140/90 as it was at blood pressures of 200/110. And we had 86 women running systolics over 200. So this was a big data set. So the relationship between blood pressure and eclampsia was very weak. What we did see was huge, very high creatinines with the higher blood pressures. But one of the slightly surprising things was this risk, which was in the women under 19 years of old, they had a 30% risk of eclampsia. And this was well kind of phenotyped clinical study data, whereas the women over 30 had a 4%. Which tended to be in the younger women and the girls who were getting pregnant. So this really piqued my interest, and there are some meta-analyses out there showing that the eclampsia and severe morbidity rates in the teenage population are considerably higher, and it's a rather interesting pathophysiological paradigm. So we showed that a huge number of babies were dying antenatally, and this was obviously an opportunity for intervention. It really was the sort of prerequisite to our Cradle 4 trial, showing that earlier delivery saves a lot of stillbirths. But looking at the teenagers as a specific group, I work with some really fantastic midwives who have pioneered basically a social intervention called 2 Young Lives, and they've got a great interest in adolescent mothers. And somewhere between 10 and 20% of women being pregnant in the world are adolescent. And in fact, because it's illegal to be pregnant as a child, this is hugely underreported, and it's probably much higher than this. But there are special features, both social and otherwise, about teenage pregnancies. They tend not to seek care. They may have different pathophysiology, and for all the reasons that Anatine's been telling us, the exposure to antigens early on, this sort of lack of cohabitation with your partner, and being a first pregnancy and so on, sort of fits that sort of risk profile of an immune mediated disease process. So we were very interested whether they were genuinely more likely to get severe disease, and did they present in a different way, and were there social or pathophysiological reasons why they were worse off. What we're seeing in places like Sierra Leone is 40% of all the deaths are occurring in teenagers. So although they are a smaller proportion than that, they are disproportionately represented in the mortality statistics. And when you're talking about 40%, you really want to do something about that. And also the thing you do about it, of course, is very different because of the social issues around teenagers. When we first went to Sierra Leone, household surveys were showing that 10% of the teenagers were dying in pregnancy. And the Two Young Lives team in our CRIBS program has just finished a clinical trial of mentoring with an elder woman that essentially showed that if you look after these girls and you make sure they get care and you give them microfinance and get them back to their parents or into work, you completely turn that around. And in 366 girls mentored in the trial, not a single girl died, and the death rates in their babies plummeted. So the primary outcome to that trial was mother and baby death, and we reduced it by 50%. And numbers needed to treat, you only had to mentor 18 girls to save a life. So for us, this was a really exciting finding, and we really wanted to know the mechanisms of the benefit. And I think the pre-eclampsia side was something that I was very interested in. So we went back to our original data sets to try and find out whether there's a relationship between eclampsia and teenagers. So this was the aim. We were lucky in that we had data from around the world from our previous studies. And when you collated them, you ended up getting very large data sets. Now, to put this into context, the magnesium sulfate trials, for example, that is the kind of reason why we use MAGPIE trial, why we use mag sulfate, only had, I think, 140 eclamptic fits, of which 70 received mag sulfate, something like that. Whereas when we collated all our lots, we were able to get over 3,000 women who had eclamptic fits. And I thought, well, this is an opportunity to start looking at things in a bit more detail. So of the 600,000 people in our studies, about 1 in 200 were having an eclamptic fit. Huge variation depending about where you were in the world. But one really interesting thing is 34% of the eclamptic fits were occurring in adolescent models. In adolescent mothers, which was clearly a disproportionate amount of eclampsia, which was a very hard categorical endpoint representing severe disease. And so we're able to model this on the expected rates if they were the same as the background rates. And essentially in all countries except Ethiopia, which we're still struggling to understand, there was this significant increase, not as alarming as we saw in South Africa, but definitely ranging between about 1.5 to 3 times higher eclamptic rates in that population. So we've actually gone on and looked a bit further at this. We found the same thing in our more recent data sets in Zambia, where Chileshi has kind of demonstrated that probably something like 3% versus 11% rates of eclampsia in the teenage girls. And Candice, one of our fellows in Sierra Leone, is looking further at this, and we've shown that the girls seem to be presenting at a lower blood pressure for the same disease profile and for the same level of angiogenic markers. So I think it's a combination of a worse pathophysiological insult coupled with that perfect storm of, being abandoned, not seeking care. And I think in terms of an intervention, they're a really special group to target if we're really going to make a difference to saving mothers in pre-eclampsia. So basically, in summary, we think eclamptic rates are different. There are reasons from immune maladaptation. There are various theories around uterine immaturity that may fit, with why they do get this insult. We also know that there are big socio-demographic features that we can tackle because of this issue of stigma, insufficient support, delays in care seeking, poor engagement with maternity care. And I think the mentoring scheme of Two Young Lives, which, is a real lifesaver, we want to kind of hone in on exactly why the benefit and what we can recommend it for other sort of low income settings and other settings to make a big difference to maternal mortality worldwide. So it's a relatively brief presentation. If you've got queries, very happy to answer them. But I think it's just that, look, another area that I think has interesting pathophysiological issues And I will probably hand over to Katie a little bit sooner. But I think it's an area which will be certainly interesting to investigate. Thank you, Jimmy.
I know we've got an extra few minutes here. Can I just ask before we move on? You talked about there's increase of eclampsia in this group, and also there's a higher death rate. What do they die from?
Yeah, I mean, we are looking at that, Jimmy. You know, we have in our data sets sort of reasonably good characterization of causes of death. I think there is crossover because we tend to only get the primary cause. The other problem is that you diagnose hypertension by the blood pressure. And if these women are dying before they have a diagnosis of preeclampsia, because their blood pressure has not tricked that threshold, but it's still a preeclamptic pathology, like they come in with their abruption or they bleed, I think we might misdiagnose them as well. So it's not as easy as you might think, saying, oh, yes, we know why they die. But it is the sort of subject matter of our current work to try and look at those causes. And I suspect we're going to have to redefine how we diagnose preeclampsia in this subgroup. And I'm hoping things like the angiogenic markers will help supersede, you know, the traditional way of just looking at your blood pressure level.
One of the problems in the past, I mean, over the last 10 years, has been a lot of the time when women died of AIDS in pregnancy, it was put down as some other pregnancy problem because they didn't want to admit that there was AIDS and they had AIDS. Is that something you've come across, or is that less of a problem now?
I mean, less of a problem, but I do think that the stigma issue, for example, many of the teenagers do not admit that they are, you know, under 18, for example, if that's what the law says, you shouldn't be pregnant. And so if you look at the subgroups of the 18 to 20-year-olds, there's suddenly this kind of increase in problems there as well. So there are stigma issues, you know, affecting that.
Right. Thanks very much, Anna. It's really very interesting work.